Cloud. Yeah. How was the physics test today? So,
The test kicked me out
oh no.
3/4 of the way through. And Larry and I had to troubleshoot. That was good times.
Good times. Yeah. Sounds like it.
Totally didn't mess up my flow at all.
So if anyone else, decides to log on, I'll let them in. But so this is being recorded. So, if you want to go back and review and, look at it at a later time, you can. I know there's a couple of students told me they weren't going to be able to make it. So I'm recording it. But I just wanted to just go real quick over pre-stenotic versus post-stenotic waveforms. Because I feel like as a class as a whole, we didn't really grasp this concept well enough, to understand what a waveform will look like pre-stenotic versus post-stenotic. So I drew on here, this is like a picture of a brain. So this is a blood vessel, one of our blood vessels going to our brain. So it could be ICA, vertebral. And if I were to put a stenotic lesion or an occlusion in this vessel here, getting up to the brain, we have to then look at that and understand where we're Dopplering, if it's post-stenotic or pre-stenotic. So if I'm Dopplering the vessel over here, that would be considered post-stenotic. So I'm post or past that stenotic lesion or occlusion. If I'm Dopplering the vessel over here, this would be considered pre-stenotic or before the lesion. This would be post, and this would be pre. So our waveform is going to look very different depending on whether we're past that lesion or before that lesion, pre-stenotic. So our post-stenotic waveform, this is going to be that targus-palgus waveform. So we're going to have that slow systolic upstroke and slow downstroke. It's going to be our pyramids. So it's going to be low velocity with diastolic
Stan, when you get a chance, can you let Denisha in?
Oh, yep, you got it. Thank you. Go let her in. Joining. Okay, good. Hello. Hey, Denisha. So I was just going over real fast, just the difference between post-stenotic versus pre-stenotic. So this was just kind of a picture I drew. So this is like a brain and a vessel going up to the brain. So this could be your ICA, vertebral. So I was just describing that if I put an occlusion or stenotic lesion here, if I'm sampling the vessel on this side of the lesion going up to the brain, this would be considered post-stenotic. I'm post or past that stenotic lesion. So if I'm sampling the vessel down here, that'd be considered pre-stenotic because I'm before that stenotic lesion or occlusion. And we have very different waveforms depending on whether we're post-stenotic or pre-stenotic. So post-stenotic, after that lesion, that's when we get that tardius parvis waveform, our low velocity, our slow systolic upstroke. The reason we get that slow systolic upstroke is because we've really essentially lost a lot of that influence of the heart, that force of the blood from the heart, forcing that blood through the artery. So now what's really drawing that blood up the vessel is really the brain kind of sucking on it like a straw, saying, hey, I want that blood. So it's gonna draw that blood up the vessel to get up there. So that's why you have diastolic flow, because now there's really nothing impeding that blood flow getting to the brain. So you get a diastolic flow component post stenosis. The velocities are going to be less because you don't have that force of the heart. So it's going to be low velocity with diastolic flow. But if we happen to be sampling pre-stenotic before that lesion, so these waveforms are going to be high resistance. Little, no diastolic. This is going to be that systolic thumping that we get, where we just kind of get our systolic peaks with little to no diastolic flow. Systolic thumping. So that blood flow now is coming up that artery. It's hitting that occlusion. And minimal to no blood flow is getting through. And that results in a lack of diastolic flow or high resistant waveform. So pre-stenotic is going to be a high resistant waveform. Post-stenotic will be our tardius parvis low resistant waveform. And then to take it a step further, we can actually assess the stenotic lesion itself. So this is kind of just a general overview of pre-stenotic versus post-stenotic. The doctors would then want us to evaluate what's going on in that stenotic lesion. So that's when, our carotid ultrasounds become very important because they want to know exactly how stenotic is that lesion, how severe, what are the velocities at that particular point. So now we're gonna now call this a stenosis. So as we're approaching that stenotic lesion, velocities are going to now begin to increase. So as we approach the stenotic lesion, both peak systolic velocity and end diastolic, oh, I'll just put EDV, end diastolic velocities will increase. So now I'm talking when we're actually like in the stenosis. As I say, as we approach, we're like right before the stenotic lesion. So we'll draw our lesion down here again. So we have our stenotic lesion here. So now we're sampling right before that lesion. And we notice now that velocities are starting to increase. With our carotid exams, we're taught to Doppler before, in the lesion itself, in the stenotic lesion, as well as post stenosis. So just before the stenotic lesion, we're going to have increase in our peak systolic velocities and increase in our end diastolic velocities. So we could say, we'll call it 250 our peak systolic velocity. So we know that that's over our threshold of 230 centimeters per second, which would make this lesion greater than 70%. We can say our end diastolic velocity could be, we'll make it 120. 120. So that also would then fulfill that criteria of an end diastolic velocity over 100. So just before the stenotic lesion, we start to see increases in both the peak systolic and end diastolic velocities. Within the lesion, we get maximum peak systolic velocities and end diastolic velocities with significant spectral broadening. So now we are in that stenotic lesion. What's going to happen to our waveform is we're going to have a sharp rise in those velocities. And we're going to wind up filling in of that spectral window. The waveform is going to look much thicker because now the blood flow is very turbulent through that stenotic lesion. So we get spectral broadening due to turbulence. Now we can potentially have velocity saying, you know, maybe this is 400 now. We know that is a severely highly stenotic lesion. So then as we progress through our stenotic lesion and we're sampling, looking for those highest velocities. So you're going to take multiple samples, you know, you're going to really, when you have these really high velocities, like I said, I always like to turn my scale all the way up to get rid of as much of the aliasing as I can. So within my lesion, turn up scale to reduce aliasing. So by turning that scale up, we can reduce some of that aliasing that we get within that lesion, and we can sometimes focus on what is the highest velocity jet and put our sample gate on that highest velocity jet through that stenotic lesion. So we can really, you know, get our maximum velocities. So now, once we come on the other side of that lesion, we are now post-stenotic. So after lesion. Velocities begin to decrease. But still demonstrate turbulence with difference mean beginning presence of TARDIS Arbus waveform. So what that means is once we pass this stenosis, we're going to start noticing that slope of our systolic upstroke becoming less and less. So after that stenotic lesion, we may still have fairly fast velocities, or we're not going to notice that that slope is more decreased. So it's not going to be as sharp of a slope, and we're still going to have turbulent flow. So we're still going to have elevated velocities, but our waveform is going to change now. We're going to have more of a TARDIS parvus waveform because we are now post-stenotic. So pre-stenotic, before stenotic lesion, we're going to have high resistant waveforms because that blockage or occlusion or stenosis is preventing the blood flow from getting to the brain. And then post-stenotic, we're going to have TARDIS parvus waveforms with diastolic flow. Within the lesion itself, we're going to have our highest velocities. and the most turbulent flow. And it's important to remember to sample through that stenotic lesion. Let's see. So I wasn't really gonna go through anatomy. I think you guys are pretty good with like the anatomy stuff. What did you guys want me to start in on? Should I start with some of the venous stuff, or do you want to do some more of like the carotid stuff?
So like whatever's on the final, let's like start there.
Start there.
I don't know.
All right. So what would be one common form of arrhythmia that we know of? Like, or one of the most common forms of a heart arrhythmia?
AFib.
AFib. Good. Let's see. Can anyone define amaurosis fugax? Like what that is?
Vision loss in half, like one eye and half of the visual field.
So
Or is that the whole blindness?
yeah, that's the other one. Yeah. So it's a temporary shading, or they call it pulling the shade down over the eye. So it's a temporary transient blindness in one eye. That is caused. So it's ipsilateral. It's on the same side of the ICA or ophthalmic artery that is occluded or has the issue. So just remember with amaurosis fugax that like the eye side of the eye that's affected, the eye that's affected, it's the carotid artery that's on the same, the ICA on the same side, or the ophthalmic artery on the same side that's affected. All right, how about this? We'll do venous reflux waveforms. So No, that's too big. All right, so one way we could test for venous reflux would be with Valsalva. So if we have the patient Valsalva, we have our normal venous waveform, we have them Valsalva. This would be release of Valsalva. This is the Valsalva period. So our reflux would be blood flow going above the baseline. So if we had our color on, anytime we go above and below the baseline, that also will represent a change in color on your screen. So if we're imaging our vessel and we're making veins blue, our normal venous waveform or our normal venous color flow would be blue below the baseline. When they Valsalva, we'll get a vessel color flow and the vessel will then turn red. So that baseline, that 0 point represents, the direction between forwards and backwards flow. So for venous reflux waveforms, when we have the patient Valsalva, if there is reflux, it would represent itself as a change in flow direction above the baseline. We would measure the time period. So along the bottom of your spectral tracing, you'll have little ticks that'll indicate, seconds. So we can measure the number of seconds for the reflux. And significant reflux is anything that's going to be greater than half a second, so 0.5 seconds. So the other thing we can do, or there's two other things we can do. We can also do distal compression. So with distal compression, this is when we're augmenting the calf distally or further down than what we're imaging. So we have our probe higher up in the leg and we're squeezing lower down, say by the calf. So our normal response, we have our normal venous waveform. When we squeeze by the calf, we should get an augmentation. That's normal. But if there's reflux present upon release, so this is release. We then get a reversal of flow. So that would be a positive reflux waveform. And the third thing we could do would be proximal compression. So this is when we're doing compression above the level of where we're imaging. So say we're now imaging the vessels of the calf, we're compressing up by the thigh. we have our normal venous waveform. And then we compress, we should have a cessation of blood flow. So blood flow should stop because we're essentially cutting off the vessel. But if we then get blood flow above the baseline, that would be our reflux. And then a return of normal blood flow upon release. So that's our release.
So with proximal compression and Valsalva, they're like similar or gonna look similar.
Yep, yeah.
Cool.
Yeah, so if it was a normal study, if there was no reflux present, when we Valsalva, blood flow would just stop. So, we'd have them Valsalva, blood flow would just stop. And then when they release Valsalva, normal venous waveform, or normal venous flow should continue. With distal compression, if it was normal upon release, we don't get that flow reversal. It would just be a normal return back to venous flow. And same with proximal compression. Well, not same with proximal compression, similar to Valsalva. So with proximal compression, if it was a normal study, when we compress the vessel, we'd have cessation or stoppage of the venous blood flow, and then a return back to normal venous blood flow upon release. So it's also important to understand too, for this class as well as for the registry, the correlation with color flow imaging. When it turns red versus when it turns blue or continues blue. Because sometimes the registry might try and trip you up and trick you, they'll put the color box like steered the wrong way and make the vessel red when it should actually be blue. We can go over that a little bit more as well. Does everyone know where a carotid body tumor is located?
Yeah, between the ICA and ACA.
Yep, good. So it's going to be carotid body tumor. When you get that picture on your test or on your registry, that it's going to only look like one thing, That's going to be a carotid body tumor. It's going to be this heterogeneous mass that has some vascularity that sits between the external and internal carotid arteries. So it's going to be right in that fork. So you'll typically get a picture of a bifurcation. You're going to have a mass or heterogeneous looking mass sitting right in between, your ICA and your ECA. Going to be your carotid body tumor. We talk quick about perforator veins. Veins. So perforator veins, they connect deep system with superficial system. There are connection between the deep veins and the superficial veins. So I'm gonna make this one our greater saphenous vein, GSV. We'll make this one our posterior tibial vein. So under normal circumstances, what's gonna happen is blood flow is gonna go from the superficial veins into the deep veins. So normal blood flow through the perforators is from superficial to deep. Normal blood flow direction is from superficial to deep. That's normal. With incompetent perforator valves, meaning valves that leak blood flow goes from deep into superficial. So with reflux, so now you're going from the, say, the posterior tibial veins back into the greater saphenous into a superficial vein. So this is just an example. So you can have perforator veins, connecting between, say, in the calf, between the posterior tibial and the lesser saphenous or small saphenous, or they could be connecting, to the greater saphenous. But just remember, perforator veins will connect superficial and deep. So it's not going to connect two deep veins. You're not going to have a perforator between, say, the posterior tibial and the peroneal veins. You're not going to have a perforator between peroneal veins and soleal vein, or gastrocnemius vein and soleal vein. So they connect superficial and deep systems. And when there's reflux and the valves are incompetent, the blood flow goes from the deep system into the superficial system. And that's why we end up with dilated superficial veins. Varicosities. We get, as a result of these incompetent perforator veins, we wind up with varicose veins because the superficial veins become dilated. The superficial veins then back up into the superficial varicosities, and we wind up with varicose veins. So if you happen to get a job working in a vascular lab where they do a lot of venous ablations, there's going to be a lot of imaging of your perforator veins to check the competency of those perforator veins. So I had mentioned it briefly in our lecture for transcranial Doppler. Um, So TCD, our transcranial Doppler, is the most useful imaging to assess for vasospasm. Post subarachnoid hemorrhage. So that's going to be when they do transcranial Dopplers in the hospital, that's their like pretty much one of their number one indications is to rule out vasospasm, post subarachnoid hemorrhage, post brain bleed. So can anyone tell me what patient position is best for doing a reflux study or assessing for insufficiency?
Standing.
Standing, yes. So that's why we even have the test called the standing reflux test, which is terrible and horrible on your back. But yeah, so we like to have the patient standing for doing reflux studies. Let's do anterior versus posterior circulation symptoms. Anterior versus posterior circulatory symptoms. So first off, we need to know which vessels are associated with anterior circulation. So that's going to be our ICA, our middle cerebral artery, MCA, anterior cerebral artery. We put on ophthalmic. And as a collateral channel, we can also add ECA. And anterior communicating artery. So our posterior circulation, this is going to be our vertebral-basilar circulation. So this is going to be vertebral. Posterior cerebral artery. Put posterior communicating artery. Well, that would be our collateral channel. All right, so for symptoms. So these are going to be localizing. Posterior is non-localizing. Unilateral symptoms. These are going to be bilateral symptoms. No, we'll do posterior first. So in addition, we're going to have our bilateral symptoms, would be bilateral vision disturbances, diplopia, double vision. Our big one over here is going to be vertigo. Feel like the room is spinning. Over here we'll have syncope. So under syncope, I'll call that blacking out. And fainting. We also have drop attack. So drop attack is when you do not lose consciousness. So do not, so don't lose consciousness. We also have headache. Ataxia. So that ataxia is a loss of muscular coordination. So ataxia, that would be like, you hold out a pen, they tell you like, grab this pen for me, and they're like, they can't, grab the pen from you, or tell them to touch their nose, they can't touch their nose, they're like touching all over their face. So under anterior circulation, so we know that these are going to be our unilateral symptoms. So it's going to be our paresis or slight paralysis or hemiparalysis. You can say hemiparalysis. So that's weakness / slight paralysis. So hemiparesis, we can have hemiparalysis, where we actually have no ability to move the limb. Hemiparalysis. We can have dysphagia. Yes, dysphagia. So that would be slurred speech. Difficulty speaking. Those patients are using the wrong words maybe, or they're talking, it doesn't make any sense what they're saying, you know. They're mixing up their words. Aphasia. That would be no speaking. So the reason speech is considered localizing or lateralizing is because the speech centers of the brain will depend on your handedness. So if you're left-handed, the right side of your brain is going to control your speech. And if you're so if you're right-handed, the left side of your brain is going to control your speech. And if you're left-handed, the right side of your brain is going to control your speech. So we can determine, you know, the side of disease based on the patient's handedness. So under anterior circulation, we also have, I'll put over here, amaurosis fugax. Spell this right. Amaurosis fugax. So this is the temporary, partial, or total blindness of one eye. Patients typically describe a temporary vision loss as a shade coming down over the eye. And it's typically due to a lesion in the ipsilateral carotid artery. Actually, one more I forgot to put over here under posterior is dysphagia. So I'm going to underline that G, not to get confused with dysphagia with the S. Dysphagia with the G is difficulty swallowing.
Hey, Dan.
Yeah,
I have to take my son to soccer practice, but
Okay.
just wanted to thank you for doing this today.
yeah, no, of course.
Thanks a lot for recording it too.
Oh, you got it.
All right, bye.
All right, take care. So you guys know the differences between TIA, rind, and CBA? Like the minutes, or not minutes, probably, yeah, so like a TIA, the transient ischemic attack. Patient has neurological deficits which improve within 24 hours or return within 24 hours. Their neurological deficits go away. So that's also called your mini stroke, your TIA. So cerebral vascular accident, we know that those are permanent. Rind, they symptoms usually return within a week, it says, like after 24 hours, and they usually resolve or take slightly longer than 24 hours to resolve. But brain tissue damage recovers completely. Credit study. So the most common location of extracranial carotid plaque formation is going to be at your carotid bulb. Some other common locations would be the proximal takeoffs of the vertebral arteries, the aortic arch, or also the origin or takeoff of the common carotid artery. But by far and away, the most common location is going to be your carotid bulb for carotid plaque formation.
How many questions is it?
Let's see. Da-da-da-da. This is it. Looks like it's out of 102 points. There's some labeling questions, which we've seen already. I think you'll all do fine on basic anatomy labeling. So those like that's 10 points, 12 points. That's a good one. All right, let's do some views. So if we're doing our DVT study, when we're doing our leg Dopplers, and we're in transverse, you guys remember what this vessel is here? One of our first pictures when we're doing our leg Dopplers.
That the grade
GSV.
This one's going to be
On
our
GSV.
common femoral vein. This is going to be our GSV. This is going to be our common femoral artery. If we see just one, if we see two vessels, two arteries, and we have our superficial femoral artery or SFA or just femoral artery. And this would be our deep femoral artery or profunda, the bottom one. To know that this is our common femoral vein and greater saphenous vein. DVT. DVT can cause pulmonary embolism. DVT can also cause venous reflux. DVT can cause venous hypertension. So So what that means is we have a clot sitting in the vessel. We now have increased pressure within that vein because blood flow is being impeded. It's not getting through that vessel. So that clot is blocking the blood flow. So in that vein, below the level of that clot, we have venous hypertension. We have elevated pressure within that vein. The DVT can cause venous hypertension, can cause venous reflux. DVT. So acute DVT. Vessel is dilated. Compressible. Thrombus appears hypoechoic, hypo. Sometimes it can even look almost anechoic if it's real fresh. The thrombus appears hyperechoic, so the vessels become dilated as a result of the thrombus. They're all clotted up, they become large, they become dilated. They're non-compressible. Thrombus appears hypoechoic. Chronic DVT. Chronic DVT vessels are usually atrophic, meaning that the vessels become smaller. They're partially compressible. Thrombus is echogenic. Slash hypoechoic.
Dan, can you move that down a little bit?
Yeah.
Thank you.
Camera, there we go. So chronic DVT, the vessels are usually smaller, they're more trophic. They're usually partially compressible at this point. Thrombus is echogenic or hyperechoic, whereas in acute DVT, that thrombus appears hypoechoic, almost anechoic. The vessels become dilated with acute DVT. They're not compressible. The chronic DVT, you can usually compress the vein out almost completely, but depending on how much scarring within that vessel there is, it still may be not fully compressible. So that chronic DVT is going to look like linear echogenic hyperechoic echoes within the vessel.
Hey, Dan, will we have any of the, I know I was getting confused with the images that we had with the flow, showing the flow, whether it was red or blue. I don't know
Sure,
if you have one that you can kind of explain a little bit more.
sure. That's pretty good. So we'll just assume that we'll just pretend like we're doing carotid arteries. And we're assuming the blood flow is going in this direction towards the head. So this is a long view. So again, I'll give you our head. I have a color box. And I'm steering in this direction. So our ultrasound beams are coming out at this angle. So the angle of our ultrasound beams is going to be the angle at which we steer our box. So we want, when we're steering our boxes to try and get a good Doppler shift, we want to be almost as parallel to that vessel as we can when we're steering. So in terms of flow direction, if blood flow is coming up the vessel this way, this blood flow is headed towards our ultrasound beam. So it's coming towards the beam. So they're kind of like intersecting each other. They're coming at each other. So that's going to create a positive Doppler shift. And if we're doing our scale, we have positive 20, negative 20, and we're making the positive red and the negative blue. Since it's coming towards us and we have a positive shift, thus it's going to appear as red. If I kept my color box, in that same position, I get a vessel running the other direction. So blood flow is still going up towards our head. But now blood flow, you know, it's still going in this direction towards the head. But now instead of coming towards the ultrasound beam, that blood flow is running away. So my beam is coming down this way, but the blood flow is also headed in this general direction away from each other. So the blood flow is in this segment is actually running away from that ultrasound beam. So that creates a negative Doppler shift. So then this segment would then appear as blue. But if I had that same vessel, and I steered my box in the other direction, you can see the ultrasound beam is now coming in this direction. The blood flow is still going this way, and it's still running away. So by steering, you're not going to necessarily change the color of that vessel. So like you have to look really at what direction like the blood flow is going, and if it's coming away from that ultrasound beam or towards that ultrasound beam. So if I had a vessel that was a little tortuous and curved, you kind of have to look at the entire thing at different segments as to whether the blood flow is coming towards your beam or away from your beam. So, you know, for this example, we have our blood flow still coming up the vessel. Now, in that direction. So if we have this segment, our ultrasound beam coming down this way, our blood flow is coming up towards that beam, trying to meet it. So this segment will be red. Where we're perpendicular to that vessel, we'll have no color. That would appear black. Where the blood flow is then coming around that corner and going with our ultrasound beam, or running away from our ultrasound beam, we get the negative Doppler shift, which would be blue. So that's why it's important to look at, you know, what you have your scale set up at. Like when you look at your color chart over here, when they give you an image on the test to see, you know, is a positive Doppler shift red or is a positive Doppler shift blue? So like if they give you this on the test and you knew that, you know, this was your head, you were in long, you know, this was your feet on that side, you know, you would be able to tell that, you know, even though this vessel was blue, the flow direction was still towards the head. It's still antigrade, it's still cephalid flow. But if on the test, they gave you that same image and they reversed the chart over here and made, you know, made this blue, a positive Doppler shift is blue and a negative Doppler shift is red. So then you would look at this picture and you'd be like, all right, positive Doppler shift, so blood flow coming towards my probe now is blue. And this segment is blue, so that means that blood flow is going in this direction. So that would be retrograde or antigrade, retrograde or caudal flow towards the feet. Because I'm now looking at my scalar, my Doppler shift color bar over here. And I'm seeing that a positive Doppler shift is blue. So that means that blood flow going towards my ultrasound beam has to be blue. So that means that blood flow is now reversed and headed back in the other direction, up towards my ultrasound beam. So you have to look at here and you have to look at your color, the color, within the vessel, and look at your angle of your box and the direction of your beam, and kind of put all those three pieces together to try and figure out, your flow direction.
Okay, thank you for explaining that.
Um, Let's see what else. Let's talk a little bit fast too about like compensatory mechanisms. So what's the body gonna do when you have blockages, in particular vessels? Like what's gonna be the body's response? Which vessels are gonna, exhibit flow changes? All right, so we'll do collateral. Flow. So collateral flow. So we have one potential collateral flow channel through the ophthalmic artery. So ophthalmic artery. We know the ophthalmic artery is going to be the first branch of our internal carotid artery, intracranial. So we have ophthalmic artery, collateral flow from branch connections with ECA. There are branch connections between the ECA and the ophthalmic artery, which can provide collateral flow in presence of ipsy lateral ICA stenosis. What that means is we have right ICA stenosis, right ophthalmic artery will demonstrate retrograde. Well, actually, no, let me rewind. I don't want to say that. So the ophthalmic artery will demonstrate collateral flow via external carotid artery via the ECA. So I kind of drew like a little circle of Lewis. So our ICA comes up and comes around, and we have our ophthalmic artery branching off. You know, and then ICA loops around and becomes the middle cerebral artery, and then our anterior cerebral artery goes up. So the ECA has connections through branches of the ECA with the ophthalmic artery. So if we have a blockage or an occlusion in our ICA, and we're not getting blood flow up, we can provide blood flow to the brain through collateral channels from the external carotid artery through that ophthalmic artery. So branches off the ECA will connect with the ophthalmic artery and can provide blood flow to the internal carotid artery on the same side through the ophthalmic artery. So ophthalmic artery and the ECA have a connection. And the ophthalmic artery then connects to the ICA and can provide a collateral channel for blood flow. That's one potential collateral channel which exists. So again, we'll use the right ICA as another example. We'll just stick with the right ICA. Right ICA, if you have a right ICA stenosis. Some potential collateral channels would be the right vertebral artery. So, right heart will demonstrate increased flow and velocities. And connect with ICA via right posterior communicating artery. So occlusion of the right ICA, the vertebral artery on the same side is going to increase its velocity and flow volume to compensate for that blockage in the right ICA. And it's gonna be able to get to that right ICA and feed that portion of the brain via the right posterior communicating artery. So again, this is another collateral pathway or collateral channel. If we have a right ICA stenosis. An additional collateral pathway would be left internal carotid artery. So left ICA. Will demonstrate increased flow and velocities. And connect with right ICA via anterior communicating artery. So if we have a blockage on the right side, our left side is going to now compensate by increasing flow to the brain. So we have increased flow, increased velocities going up the other side. And then it's going to be shunted over to the right side of the brain via the anterior communicating artery. So basically that's the body's main mechanism for compensation when there's blockages. So if we have a blockage on one side, you have to think about which vessels are then going to dilate and increase their velocities, increase their flow as a compensatory mechanism. So if we had issues with the vertebral arteries, for instance, we could have similar collateral flow develop. So if we had, say, for instance, our left vertebral artery occluded, the right vertebral could then show increased velocities and flow in order to get blood flow to that portion of the brain. You know, they connect, you know, with the basilar artery, they come together. In addition, if our left vertebral was occluded, the left ICA could potentially show increased velocities. And then we can get that connection, you know, between the anterior and posterior circulation through the communicating artery of the same side. So, you know, it's up to you to kind of just sit down and just slowly break apart the question, you know, like, all right, which vessel is blocked? And what are my pathways, you know, to get around that blockage? Like what other channels are there in the brain that are open? So the main ones are that the circle of Willis, and then, you know, that also connections with the ophthalmic artery and the ECA. Trying to see everyone's faces now. I just have like my little screen on my board. I was staring at myself for 2 hours. Smile, everyone. Come on, smile. Smile. I was gonna teach this lecture in a clown hat just to have your attention, but I thought against that. I was like, gotta keep out. Who's this idiot teaching in a clown hat?
We've been smiling, Dan. You just haven't been paying attention.
You're right.
Yeah, we were smiling the
tears.
whole time.
Smiling
The
whole
entire time.
All right. I don't know. I think what other, let's see what else. What else
You've
we
been
got?
lecturing all day, Dan. Did you eat?
Yeah, I did.
Do you have a donut?
Oh my God, I had 5 of them by the time I left. Does Coke count as, no, I guess
No.
not.
No, this doesn't count as one.
See. I think you guys are gonna be okay. Like, I got, signs and symptoms of stroke again, like knowing which is anterior posterior circulation. TIA, CBA, Rhine. I guess also if there's a little bit of flow within a vessel, it's not fully occluded. So that's considered trickle flow. So there has to be absolutely no flow for it to be considered occluded. Oh, do you guys remember your for that photoplethysmography, for the venous stuff, the venous refill times, like with the tourniquet, without the tourniquet? Want to do that again?
Go for it.
Go for it. All right.
Sure, I need a little bit of reflection. I'm sorry, reflection. I can't even talk.
Reflector. I
I
got
need
you.
a little bit of refresher on that. Why can't I talk?
Reft ICA.
Spit it out, Dinesh. Just spit it out.
It's all right. It's dysphagia, right? All right. Going on, venous reflux. So this was that test where we put the PPG sensor on the patient's ankle, about 5 centimeters above the medial malleolus, the photoplethysmography. And we calculate our VTR, our venous refill time. So normal venous reflux time, VRT, or sorry, venous refill time. Jesus, venous. I'm dyslexic. ERT, venous refill time. So normal.
We're
venous
dysphagic.
Yeah, right. I'm dyslexic. That's a posterior circulation problem. Normal venous refill time is going to be greater than 20 seconds. So if we do our test where we have the patient, pump their calf 5 times to empty the blood flow in the calf. So that's the one that we get our tracing, where it was up here. So they pump, they pump, they pump, they pump, they pump. So if we get a slow, gradual return back, that's normal. So if it's greater than 20 seconds, That would be normal. That would indicate no reflux. So then if we have them do this and we get a fast venous refill, so if the blood flow returns back to the calf quickly, that means that we have leaky valves in that calf. So blood flow, we pump the calf, we empty the calf of blood flow goes up, but then all of a sudden comes right back down because those valves are incompetent and the calf muscle isn't being filled by the natural progression of blood flow from the arteries through the capillary bed. So BRT, which is less than 20 seconds with tourniquet above knee. It could mean reflux, and the deep veins or small saphenous vein. So that tourniquet above the knee eliminates GSV. So that's going to eliminate the greater saphenous vein. All right, so we'll just kind of go back again. So we start our test. If they have a normal venous refill time of greater than 20 seconds, there's no reflux, beautiful, we don't need to do anything else. But if we do our baseline with no tourniquets and it's less than 20 seconds, all right, patient has reflux. So we move on to the first step. We place a tourniquet above the knee. So remember, this patient is sitting on the edge of the bed, or they're sitting in a chair, the legs are dangling down. We place the tourniquet above the knee to eliminate the greater saphenous vein. So the tourniquets, also remember, they only work on the superficial veins. So we can't put a tourniquet and cut off a deep vein, circulation in the deep veins. So we place a tourniquet above the knee. If the venous reflux time is less than 20 seconds, then that could indicate reflux in either the deep vein or the superficial veins. So what that's saying is we've eliminated the greater saphenous vein by putting the tourniquet, but we still have reflux. So what other veins could potentially still be involved? So it could still potentially be a deep vein, or it could still potentially be the lesser saphenous vein in the calf that we're getting the reflux. If we put that tourniquet above the knee and we now have a normal venous reflux time that's greater than 20 seconds, then we know that the culprit was the greater saphenous vein. So if we're continuing with our test and we still, have a venous reflux time, which is less than that 20 seconds, if it's filling quickly, it means we still have reflux going on, even though we've eliminated the greater saphenous. We'll then place the tourniquet below the knee. So then if we have a VRT, which is less than 20 seconds, below. reflux. There's deep vein. So that tourniquet below the knee will eliminate both GSV and small saphenous vein. But if we place that tourniquet below the knee now, and we returned back to normal, the venous reflux time that is now greater than 20 seconds, with the tourniquet now placed below the knee, then we could eliminate, we then ruled that the reflux would be in that lesser saphenous vein. So with the tourniquet below the knee. So we've done above the knee. And it was less than 20 seconds, which showed reflux in either the deep or the superficial. We then moved below the knee and it normalized now. So then we know that it wasn't the deep veins that had the reflux, it was actually the lesser saphenous. So, you guys kind of understand that? Might take just a little bit. Just kind of going slow and breaking down the question, So don't try not to rush. Take your time and just kind of think about it logically. Like, all right, I'm cutting off circulation here, and I still have reflux. So if you have a fast venous refill time and you've put tourniquets both above and below the knee, then the issue is in the deep veins. And quickly, I know Morgan wanted fistulas. All right, so fistulas. AVF and AVGs. So the difference between an AVF and an AVG, the AVG, this is going to be a synthetic graft. And typically our AVFs are going to be our native vessels. So this is going to be our loop grafts. Or straight grafts. And these are going to be our fistulas. So AVF will have one anastomosis AVGs will have 2 anastomosis. So for the AVG, so first anastomosis. That's going to be at the arterial side. And the second anastomosis is going to be at the venous side. So AVG, these connect artery with vein. And AVF is a connection between an artery and a vein. So that's why we only have one anastomosis. So think of an AVG as a tube that's going to connect your artery to your vein. With an AVF, we're actually making a direct connection right between the two. So we don't have a synthetic or man-made channel connecting the two. So that's why we only have one anastomosis, that connection point between the artery and the vein.
Thank you, Dan. I have to leave. No,
Okay.
I have to bring my kids. Thank you.
You're welcome. All right.
Yeah,
so
I have
AVF.
one too. Thank you.
You're welcome. Nobody wants to play with me.
I
I
gotta
know
make.
I have to get ready to log on too. I have to get my
All right, so I'll do this quick. So AVF.
Okay.
So we got blood flow in our artery. So blood flow going in this direction, down the artery. So blood flow should continue down the artery. This is our anastomosis here, our connection between the artery and the vein. So arteries, we know, are under high pressure. So blood flow is then going to be shunted into our vein, which is lower pressure, and head back up in the opposite direction. So this is kind of goes along our lines of our pre-stenotic, post-stenotic waveforms. So with a fistula, if we're sampling our artery before that anastomosis, the artery is now, normally our peripheral arteries are high resistant triphasic waveforms, but arteries now before the anastomosis will now have low resistant. So pre anastomosis artery. So this is also called the inflow artery. Inflow artery. It's going to be low resistance. And high velocity. Low resistance because it's entering the venous system, which is a low resistance system. The velocities are going to be fast because we're going from high pressure in the arteries to much, much lower pressure within the veins. Your highest velocities are going to be at that anastomosis, so highest velocity. Anastomosis. And once that blood flow, the arterial blood flow enters into the venous system, it then becomes what's called mixed waveform. So we'll do here. When we get mixed waveform. So this is going to look like a combination between both an arterial and a venous waveform. So you'll see some pulsatility to it, but it's going to be very turbulent and have properties of both venous and arterial waveform. So we don't really measure end diastolic velocities anymore. We'll just measure peak systolic velocities. And we can also calculate flow volume as well. There's functions on the machines where we would measure the diameter of the vessel and place our calipers, between our peaks, and it would actually trace and measure flow volumes. But I'll teach you guys that at another time. We don't need to know flow volumes for this.
Cool. Thank you.
So with AVGs, it's pretty similar. With the arterial connection. So the same thing, that arterial, the first anastomosis where that graft connects with the artery, you'll have the same thing. You'll have your highest velocities. You try and look for both anastomoses with the graft. So you want to see that arterial connection. You want to image that venous connection as well, because that's where your two stenotic lesions could potentially develop at the anastomoses of the graft. Typically, you should have same velocities throughout the entire graft because they don't really dilate in size or change in size. We typically do a synthetic grafts when fistulas aren't an option. If we've done the vein mapping, the veins vessels don't look good, they'll go to a synthetic graft option, or if they've had fistulas and they've failed in the past, we may only be left with options to do a graft. So the vessels, remember, we needed a slightly larger vessel if we're using a graft. So what was it? It was 0.3 for the vein if we're doing an AVF, and 0.4 if we're doing a graft. So 3 millimeters for an AVF, 4 millimeters for an AVG. And do you guys know what a VQ scan is? The ventilation quotient scan, the nuclear medicine test to detect the perfusion in the lungs. So it's called the ventilation quotient scan. So it can also use to like determine possibility of a patient having a PE, and it's graded as, low, medium, or high probability. But it's not like a definitive test for PE. If you want a definitive test for PE, a CT angiogram is your more definitive test for pulmonary embolism, or is the gold standard for ruling out pulmonary embolism. I really don't see anything else that's going to be tricky on here, I think. I think we're good.
Thanks for doing this, Dan.
Yeah,
Yeah, thank you, Dan. I appreciate it.
you're welcome.
Yeah.
And you guys are going to be fine.
Thank
I
you.
promise.
You do?
Okay.
I promise.
So if we know this will pass, correct?
You guys
Pretty
are gonna
much.
pass. You guys are gonna.
I'm sure we're gonna have to know this consensus committee chart, correct?
Yeah, how
Yes,
many?
know
I
your
got that in my
velocity.
head
So,
now.
Tell me. Greater than 125. peak
No
systolic
clue.
Velocity is
50%.
50 to 69% stenosis. So once you get over that 125 for peak systolic velocity, you're in 50 to 69%. So also the other criteria for 50 to 69%, an end diastolic velocity between 40 and 100, and a carotid velocity ratio. So let me explain that. I know I explained it to a couple of people, the carotid velocity ratio. So,
I'm actually gonna have to sign off because I'm going to work for 4 hours.
no, it's okay.
But thank you. I appreciate it.
You're very welcome. Velocity.
Bye.
See
Yep.
y'all.
Bye, Denisha. Have a good night.
Bye. Make them
That's that
tips.
third component. So that is, our equation is proximal ICA peak systolic velocity over our distal PCA peak systolic velocity. So what that ratio is basically telling us is how fast the blood flow is accelerating. So it helps us to get an idea, like if we have our stenotic lesion, we got our blockage here. So if this is our distal CCA and that's a velocity of 50, and we measure over here and say we're getting 150. So this ratio is telling us kind of like a ratio of how fast is that blood accelerating from our distal CCA to that proximal ICA and that stenotic lesion, because this is where most of our plaque is going to be, in that bulb. So if we were to do, put this into our ratio, 150 over 50, would give us 3. So that would, fall within our criteria. If we're getting a peak systolic velocity of 150, that's over that 125, between 125 and 230. So that'll put us in the 50 to 69%. And if our systolic or our carotid ratio was 3, that would put us in that same criteria. So for 50 to 69%, it's between 2 and 4. So the reason they do this whole ratio is sometimes our systolic velocities could be a little bit skewed. Say the patient is, you know, elderly, has a very bad heart. They're 90 years old, you know, they have an EF of like 10, you know, the heart's barely beating. So their velocities are very low to begin with. Say, you know, this is like 20, and then this is like, whatever, I don't know, 80. We'll make it 90. Just for the sake of our thing. So you're looking at that, you see a, you know, what looks like a very narrow stenotic lesion, but your velocities are so slow, they're skewed because, you know, the patient, you know, has very bad cardiac output. So if you were to put this into your equation, you're getting over 4. So this is like, you know, what, 4.5. 90 over 20. So then you look at that ratio, be like, all right, I'm getting a ratio of 4.5. That's, you know, that's a high grade stenosis, but my velocities aren't skewed. So then the radiologist could potentially look at that, be like, all right, you know, what else is going on? Oh, they got a bad heart. So, you know, it's obviously a high grade stenosis based on my ratio. So that's why they add these extra grading criteria in there, because there are situations, you know, that you may come across where your velocities are telling you one thing, but your eyes are telling you something else. And when you do this ratio, like, all right, you know, there's definitely a very large, you know, acceleration of that blood flow from the distal CCA into that proximal ICA. In a nutshell. All right,
Oh, just that?
just that. So yeah, remember your values, because there's going to be some questions where you have to look at, be like, all right, it's 50 to 69, it's greater than 70. So know that chart, Write it out.
All right.
25 to 230, 40 to 100, 2 to 4, and then greater than 230, greater than 100, and greater than 4 for greater than 70% for ICA stenosis. All right. Good luck on Monday with OBGYN. I'll see you all bright and early Tuesday morning. If there's anything that you guys think of in the meantime, email me, text me, whatever you need to do. I'll try and get back to you before the exam. And yeah.
So we're just here on Zoom at 8?
Yep.
Okay,
Unless you want to come in. Nah,
unless,
no,
not at 8.
not at 8. No.
Cool. Well, have a good weekend if you
Thank
can.
you.
If you
Yeah.
can.
Have a good
Thank
weekend.
you.
Bye.
All right, bye.
Bye, y'all.
Bye.
Bye.